Good afternoon, everyone. Thanks for joining us. I'm Chip Hurley, a Managing Director with Berkeley Research Group, and I'm going to be the moderator for today's CFO panel. First, I'd like to thank all of our HFMA Maryland chapter sponsors who've continued to support the chapter during this pandemic period. That allows us to be able to provide all of our virtual events this year completely free of charge. Our panelists today include Carolyn Heithaus from Calvert, Laurie Beyer from GBMC, Michelle Mahan from Frederick, Michael Myers from Lifebridge, Carroll. Our topics today were selected by our CFOs. We have a lot of topics, so we're going to move pretty rapidly today through those topics so we can cover a lot of areas that hopefully will be of interest to most of you. Our topics will highlight many of the financial challenges that our hospitals and our CFOs have dealt with during 2020. So they're going to include items such as specific COVID-related issues, national and Maryland healthcare trends, current threats to hospitals, and if we have time, physician relations. We have 115 registered participants today on this webcast. So we've muted all of the lines to prevent any background noise. But if you have a relevant question, please type it in the chat box. And my co-chair, who is Cheryl Nottingham, the CFO of Atlantic General, she's going to be monitoring those typed questions and may chime in from time to time and ask those questions directly to the panelists. So let's start just by letting all of the CFOs introduce themselves and tell us just a little bit about their hospitals. Laurie, you want to start?
Sure. So I'm Laurie Beyer. I think most of you know me. I've been here at GBMC since 2017. Happy to be here. And prior to being at GBMC, I was a CFO of Union Hospital, Cecil County for 12 years and learned a lot about the inner workings of finance operations, but more importantly about taking care of patients in need. So very happy to be here today to share insights about many issues we're all facing.
Michelle?
Hi there, I'm Michelle Mahan. For those of you who don't know me, I'm out at Frederick Health in Frederick, Maryland. And I too have worked in lots of different places, San Diego, DC, Baltimore, and now Frederick. All of those having been very good experiences that I could bring to Frederick, which is a sole community hospital in the Frederick County. It is the largest county in Maryland. I'm not sure everybody knows that. Consists of, I think, a lot of the typical kinds of services that a community hospital, we have medical group that continues to keep growing because of the need for recruiting physicians that are retiring in that world. So I'll stop at that point, Chip, and move on.
Sure. Carolyn?
Hi, I'm Carolyn Heithaus from CalvertHealth. CalvertHealth is down here on the peninsula here in Southern Maryland. I came to Calvert back in 2017 after spending the earlier parts of my career in Connecticut. Connecticut is not a regulated state like Maryland, so it's been a large adjustment in healthcare finance coming to regulated Maryland.
Great. And Michael?
Thanks, Chip, and thanks for having me here today. Can you hear me okay, Chip?
Yes, you're good.
Okay, thanks. Thanks for having me here today, Chip. It's good to be back in front of the HFMA group, even if it is virtually. I've been with Lifebridge now for 5 years, a very quick 5 years, operating in the role as the Vice President for Regulatory Reporting and Reimbursement, which is, of course, all things HSCRC. And then a couple of years ago, stepping into the role as CFO out here at Carroll Hospital as well.
Okay, great. Thank you all. We'll get right to the questions then. We're going to start off with some COVID-19 related questions relating kind of to operational changes, both maybe temporary as well as long-term, and some of the challenges you've dealt with there. So many businesses during this pandemic period have been successful with their employees working from home. Generally, though, hospitals are unable to do that. But to some extent, I think some of you have had some success in that area. Michael, I'm going to start with you. How have you been able to have any of your employees work from home? What departments, and do you see this as just temporary, or do you see this being a long-term issue?
Yes, I guess to coin the old cliche or the phrase, necessity is the mother of all invention kind of plays true here. I think we have for years flirted around with the idea of having people be able to work remotely and virtually from home. And frankly, the COVID pandemic forced us to do it. We tried to do it with as much of our areas, non-clinical obviously, that we could. So our overhead areas, our finance department, our patient billing services, our revenue cycle, which was a challenge initially to get folks equipped and get the technology support needs to be able to work from home and so forth. But we've tried to extend it as much as we can across what I'll call our fixed or our overhead areas. And it's been a really good experience. We've seen our employees adapt to it. And that they've done it very well. They've been very kind of productive and efficient in doing it. So I think, as we thought about it and as over the last 6 months or so we've gone through it, we looked at it as being a more longer term and permanent solution. So we are trying to, I don't know that it will on a permanent basis be exactly as it was at the height of the pandemic where people were not in the offices at all. But I do think we will afford, on a more permanent basis, the ability to work virtually for at least, call it 3/4 or more of a person's schedule to the extent they can.
Yeah, and that's similar to what I've heard from several other CFOs. But Michelle, I think you've had a little bit different experience there at Frederick.
Right. I will say that at the beginning, when things were so unknown and we really didn't understand what the impact of COVID was going to be, we did a very mass full remote concept. And we looked at those folks in categories, those that were essential and had to be at the hospital or in their service areas. Then we looked at who could be rotational. And then we had full remote. So rotational meant you came in a couple of days a week. And in the beginning, which was really like March all the way until the end of September, that's what we did. People really either love or they hate remote work. And the same way with Mike, we really didn't have any problem quickly moving. But what really was a concern, and maybe you've seen it in your organizations, is our CEO really worried about what was going to happen to culture. If everyone was remote, how did we stay with a cohesive culture? And then of course, caregivers who are frontline, when did they get a chance to be remote? And so there's definitely different aspects of this. We brought everybody back that was supervisory October 1st. And then of course, COVID kicked back in. And so back now to rotational. We will probably not go full remote like some folks have done, where they're now going to stop leasing buildings and that sort of thing. And that's, again, a cultural thing about wanting to have people be with people.
Great,
So let
thanks.
me piggyback onto that. People being with people is very important, especially as we bring on some of our young employees. But at GBMC, I'm just going to chime in a little bit. We did allow a lot of individuals to work remotely, but now we're evaluating real estate. So when we were having this prep call, when you allow your employees to work remotely, how does that impact the amount of money we spend on real estate, on our campuses? So that's something that GBMC is really looking hard at, is maybe there is a benefit to having some folks work remotely permanently, but then you can save on the real estate cost.
One of the biggest changes that I've heard about in the healthcare industry at hospitals is the use of telehealth. Why don't we stick with you, Laurie?
Yep.
How have you guys implemented telehealth?
Okay, so it's interesting, but before COVID, we had the ability to do this through Epic. And it was almost like a proof of concept, science experience, and started doing 5 to 10 a month. And then in 2019, Care First began paying for telehealth. So then we required all of our primary care physicians to do at least one telehealth visit per month. And then guess what? Then COVID hits. And we were totally ready to do this for our community. And during the height of the pandemic, from the end of March until the end of May, 40% of our volume in primary care was telehealth. And I think the question was, did it impact our volumes? Yes, it did positively. I mean, we saw about a 10% increase in encounters because of being able to allow our providers to do telehealth. And to this day, it's still, it's still a function that's available. And so 20% of our volumes today are telehealth. So I'll turn that over to my other colleagues, but I think for GBMC, we were actually primed and ready to do it. And the COVID-19, sort of pushed us, to do this more.
Yeah. Well, I can add to what Laurie said, that the same thing. We have been working with the digital strategy for some time. We joined a group called Avia out of Chicago that brings startup and other companies to the table for you. So it kind of helps you with that due diligence. So we were prepared to move rather quickly. The doctors adapted it. I think patients liked it. We have an app that's on our website you can go to. And if you're simple, you can have it all done just web-based, get your prescription wherever you want it. It's $25. We made it free for the COVID period of time. We had an app called Jellyfish that used to help control your wait rooms and keep people in the cars until you were ready to call for them. So because of what we had started, honestly, for consumerism a few years ago, we were in really good stead to be able to pivot to use those tools for what we needed in the pandemic. What's been interesting now, because you think everybody would love the convenience of telehealth, we are seeing it start to fall off a little bit though. So doctors liked it, but they really like to be hands-on over that rather than over a screen. And I'm watching that closely now.
Yes, and Michelle, we've seen the same trend. It's falling off, but what we've done is we've identified some patients, some of our OB patients who maybe don't need to come in, can be monitored remotely, our bariatric patients, our sleep patients. I mean, as we all know, providing sleep center monitoring in the hospital is not lucrative. So we're sort of looking at how can we take this technology and be able to provide different levels of care for our population.
Thanks.
And I
You
would add
mentioned-
to that just a bit of
Good, Carol.
flexibility for the patient. So, our standard practice has been 9 to 5 or 8 to 4 in our physician practice offices. So how do we extend telemedicine into maybe a bit more Saturday, a bit more evening, looking at those other options too?
Great, good idea. I know, Laurie, you mentioned that your volumes declined significantly, especially in kind of the March to June timeframe, and to a lesser extent, still most of your volumes are down. This is kind of a general question. Maybe Michelle, I think we've talked that you might take the lead on this one. To what extent did you have to terminate or furlough any employees as a result of the decline in volumes?
Okay, well, we worked very hard as one of the largest employers in our area. We felt a responsibility to the community to try to keep people employed. We didn't do any furloughs at the hospital level. We did do some furloughs in our medical group. And again, the PPP program came in there and made that actually be very neutral impact-wise to those staff. And at the I think that, I want to say that was for a period of maybe 60, 90 days. And then those staff were brought back if they were not redeployed to do other COVID work. So we really did try to avoid any layoffs or furloughs.
Anyone else?
So, yeah, I actually would chime in on that, is that GBMC had the philosophy of a pandemic and let's make our employees as whole as possible. And we're going to talk about physician compensation maybe down the road here on this session, but we try to limit the amount of furloughs to the extent possible.
How about, let's talk about nursing costs or in other staff costs as a result of the pandemic? I know a lot of hospitals were doing some creative type things. You might have had to have paid for, bonuses or overtime. Did any of you experience that? Carolyn,
Yeah.
what about you?
So like Calvert, to extend off of keeping people whole. So first off, we deployed a hazard pay program. So we provided an extra rate per hour to anyone that was in that direct line with our COVID patients. We did that back in March. We did that from around the 15th of March to right around the 1st of June. To sort of recognize all that extra work and extra that staff were putting in place. To also speak to the point of keeping our employees whole, we looked for every opportunity possible to redeploy staff. So if it was someone from the medical group, if they could be a scribe in the ICU, if they could transport patients, if whatever we could do. We also, of course, like all of us, didn't know how long this would be. So actually for 2 pay periods, which was a total of 4 weeks, we actually didn't have any employees using PTO. We kept them whole through regular compensation. And then after the month, if they weren't able to work and didn't have anything left as far as PTO, some of the newer staff, we really tried to find them to be the people that we put into redeployment mode. So of course, that added to our cost structure. Sometimes you were using someone very expensive to be filling a lower level role, but we needed all hands on deck. So between the hazard pay overtime, it really did add up in that period of time. What we've seen since, of course, as volume of COVID patients seem to dwindle off in the fall, and then in November, as that volume started to come back again, it was about retaining our staffing, just having enough staff. So now we've instituted bonus programs for our per diem staff to take on extra shifts, just to hold them in place, because going out to the market to get contract labor, we're seeing rates between $105 and $150 an hour for an RN to work with COVID patients. So we're doing everything we can to keep that money to our current employees because it's so hard to get contract staff.
Did you see nurses leave to go to work for agencies?
Yes, that's why.
Yes, I'm going to say the same thing. Yes. Yes.
All righty. How about onboarding issues during the pandemic? Any war stories about that?
Absolutely. So as we have gotten comfortable, with these virtual meetings, it's very difficult to onboard clinical staff. When in the early part of COVID, we weren't bringing them on site. So, we can only get to know each other so well through a camera. So we had definite challenges there that we ended up with the right fit in some staff members with that onboarding process during COVID. But we're doing more in person now than we did, but it is a challenging time.
Great. So while the vaccine development and emergency approval and production pretty much occurred years ahead of historical experience with vaccines, the actual vaccine implementation has been slower than projected by national and state leaders. How has your hospital dealt with this issue to try to speed up basically getting the vaccines into arms?
So,
Laurie?
Chip, I'm going to take the lead, but I would love to hear what my other colleagues are doing, because the biggest issue today is not having the doses. So our first focus was getting our employees vaccinated, and to date, we've got 50% of our employees vaccinated, and working on a campaign to get 70 to 80% compliant. So lots of initiatives there. But from a structural perspective, we assigned a clinical lead from one of our primary care practices to oversee the entire process. We have a centralized clinic on the campus. It includes a call center. And this has actually allowed us to assist our seniors. So our seniors have issues with just the whole registration process and doing all that. So that's been very favorably accepted by the community. And then when we can't help them, we have folks that help them identify resources in the Baltimore County community. And then we also have someone here in my office who has a list. So maybe they're not over 65, but maybe they are a 1C employee who can't get vaccinated. And so if we have doses available, we can get to them, call you like in 2 hours and say, vaccine's available, get you over here. And then finally, we've been partnering with Baltimore City. So I don't know if most of you know, but we have a clinic down in Baltimore with the Helping Out mission. And so they have had doses available. So we've been helping to get vaccines in the administration of arms and those in Baltimore City. So there are some of the initiatives that we've been doing. So I'm happy. I would love to hear from others of what you all been doing in that regard.
Well, I can speak to that. We set up a pretty robust testing, and we just flipped that into the vaccines as well. And the supply is definitely the issue. It's not having the supply and getting it in arms. We've been partnering with the Department of Health in Frederick. I think the issue is that the state really has wanted to move hospitals out of the vaccination business, and they have moved it over to the mass vaccination sites or to Giant Food or CVS. And the thing is, and you know, our CEO has been active with the discussions with Bob Atlas about this, is we're the only ones that really can risk stratify the populations in our area and really be able to focus and, you know, move hundreds, if not thousands of people. We've already done thousands of vaccinations. So, you know, depending, every hospital is going to have a little different setup, but, you know, again, as the only hospital in the area, we have a location that is ideal for people to come and we are able to have a large parking lot with tents. They socially distance, you know, they're not in a CVS lineup, which I don't care what anybody says, you are not socially distancing as humans when you're in a line. We just don't, you know, we group up. So, I mean, I think that has really been an issue. And, you know, we advocate that the extra doses that may come from the feds should go to these new spots and leave the existing distribution system to the hospitals alone.
No, Michelle, I totally agree with you. We've got the infrastructure ready to go. So it's very disappointing that we're going to be setting up all these mass sites and we're duplicating resources, as you know.
Right, and resources are all limited for all of us, you know, to do this. We, being in Calvert, we've partnered with public health, and so it's between the hospital and public health. But both of us are, you know, seeing reductions in the volume of vaccines we're getting, and how are we really assured that the criteria is being met at CVS and Giant and wherever else that the vaccines are being distributed to? So our high risk patients, future patients, do they have the vaccine available to them?
Okay, great.
Mike, did
Thanks.
you want to try to chime in?
Mike, you want to chime in?
That's what we're saying.
I'd agree. I mean, very consistent here. You know, we really did a lot of work and I think set up a very effective process to be able to do vaccines and really are ready to go in much more capacity than what we're getting vaccines. So it really is a supply issue for all of us. That is absolutely consistent. And I really have to, you know, kind of tip my hat to the folks here internally. They did an absolute great job in being able to stand it up, being ready to do it, and we are ready to do it. But the vaccines is really a challenge for everybody.
Yeah.
All right, let's switch subjects a little bit. Talk about capital projects. You know, obviously, capital projects take several years to plan and so forth. How have you kind of kept up with that whole planning process during a pandemic? And in any capital projects that you might have planned, have you seen that during this period that you've made changes to those capital projects as a result of things that you learned from COVID?
Well, I'll
Or
tell
maybe-
you,
Good.
we had the fun of that long-term planning and being in the middle of 2 bond deals with Heithaus when COVID struck. So we did our full closing activities remotely, and the restructuring that we did of our portfolio. So there's an example of how quick everybody was able to accommodate to virtual because we were able to get all that said and done. You know, those projects are ongoing. They're long-term. The dollars in that case are in the pipeline. I do think that we will take, you know, we had some dollars in beds that we moved to the Hercules beds that are better for the patient and better for our staff. We put reimbursement for that through FEMA. We'll see what happens. Not holding out any great hopes with that. But I don't think the capital issue has hit us yet. I think when we find our unregulated and, you know, when CARES dollars run out, because I think that's been a huge support system for us. When CARES dollars run out and we're fully facing the shortfalls of volumes in our unregulated ambulatory areas, then some of those capital projects that we've had in the pipeline for probably 3 to 5 years, I'm going to be thinking hard about how we're going to fund them. They're all necessary, and we have a way of never saying no. So I think it's back to me to sharpen the pencil.
So I'm going to chime in on that. So I would say that COVID definitely had us pause on routine capital, but we have a major capital project that has been in the works here at GBMC for the past 2 years, and it's called the Promise Project, and it's because we are promising to the community that we can provide the care that's needed. And our project is a 3-story addition to the front of the hospital to create 60 state-of-the-art medical surgical beds. And we're on track. We lost a little bit of ground because the counties had issues with COVID-19. But what we learned is that we can make it safer for our caregivers. So just a couple of examples, and I wish I could show them on the screen today, but we have a process where we can have supplies that are inside the room, outside the room. They can be loaded outside, and we're talking about medical supplies, laundry, pharmacy, where someone does not have to come into the room. So if that patient is COVID or tuberculosis or whatever, we're designing rooms to make it really safe for our caregivers, as well as this whole issue of negative pressure air flexibility. So I think we have learned through this pandemic, as we do this, move forward the capital project, that we can actually create safer means of providing care. So.
Okay, since you're all CFOs, we're going to talk finances a little bit in the bottom line. I know the HSCRC has granted hospitals some relief with the ability to charge 5% above the corridors to assist them in meeting their GBR targets. This is in part to deal with the lower volume, especially that you all saw back in the spring, and the added cost of treating COVID patients. But how has your hospital's financial results been affected because of COVID? And is the 5% enough to cover that loss of the unregulated revenue and your additional costs?
So I can speak to that for a minute here. One, I think that it was wonderful that we did get corridor relief with that, and that they recognized, and I do think that the HSCRC struggled with COVID from a regulatory standpoint, just like we struggled with it with, you know, operations and financial impact. So I really credit them with trying to help. And you know, unfortunately, we have a lot of operations in our hospitals are one component of it. What we found is that the 5% helped, but it was not enough. And that our undercharge completely absorbed the CARES dollars that we had. And I know that's not true of every hospital. That's a little bit different, but if you just use that as an example, then the 5% was a pretty significant shortfall.
No,
Are you all
I agree with Michelle. Yes, I totally agree. The undercharge we experienced was totally offset by the CARES money. So, and we still needed Carter relief, and we still need Carter relief because, as you all know, we had an IT outage, which totally impacted volumes for, December through January. We'll talk about that in a couple of minutes, but yes.
Were you all able to access?
No, that's what I've been living. Yes. I've been living this IT outage since December 6th and still living through it. So
COVID and a cyber attack is not fair.
Were you all able to access any emergency funding, federal or state grants or loans and so forth? Carolyn, how about you?
Carolyn, yes.
So of course we had available to us the ability to get advanced Medicare dollars. At Calvert, we did not take those extra dollars, but they were available to hospitals. Of course, the ability to delay, our payroll taxes, but really those were only cash flow items for anyone. Really, the extra opportunity, the CARES Act funding, as others have spoken to, has been a great savior to all of us. But as we talk about applying to FEMA for relief funds, we don't know what really will we get out of those dollars. But there are other small areas like the FCC, applications there for some reimbursements for telehealth software and such. But really, CARES Act was really the main component or the main relief that we have so far. But extending a bit on the CARES Act, we all don't know how that's all going to settle out either. So, we did get those large checks, but now we're still all struggling with how the federal government views those payments and how we'll reconcile those, as well as the HSCRC. So still a lot to be determined in this area.
Michael, how about Lifebridge? Do you have anything to add?
Consistent. I mean, clearly the CARES Act, the provider relief funds have been a tremendous support, as has HSCRC corridor compliance. We did take advantage of the Medicare accelerated payments, which are of course loans, and have been extended out. There's also been the Medicare sequestration, that being relaxed for a period of time, the 2%. So that's been very helpful as well. But I think the other mechanisms, be it the accelerated payments, have been the primary mechanism as well as the provider relief funds.
The only thing I would add to that is I did all that, the advances, the CARE dollars, but also went to the bank and set up a larger line of credit. So, again, back in March, and we had no idea what we were facing, was trying to grab as much liquidity as possible through, and didn't know that the government programs would be coming through because those were unknown at the time. So that was the only other addition that I would have to that.
I heard there was actually a run on the banks and that some of the banks didn't have availability of to grant hospitals additional lines of credit. Did any of you experience that?
Yes, we did, Chip. We did. And so we had to look to other alternative banks, but anyway, we're good. I mean, the Medicare advance has been a godsend I don't know, I'm speaking for us, just having that extra cash in the bank. And now we're gonna have to start paying it back in April, but that was just a huge lift for us.
Let's talk specific about volumes. Obviously everybody knows your volumes went down, but could somebody kind of put a frame around that? How much did your volumes go down in the spring? How much have they come back? And are you seeing any certain departments or maybe ER that have continued to have lower volumes than pre-COVID.
All right, Michael, that's your question to answer.
Yeah, I mean, I can, across the hospital system here and having 5 hospitals, I think all of us experienced very similarly in March and April, the fact that when we, voluntarily closed operating rooms, that all of the surgical volume stopped for all of April and really all of May, and really didn't start to come back online until June. Our average daily census has kind of moderated across facilities, but we've seen an increase in our length of stay. Obviously, we're taking care of a different population of people than we were pre-COVID. A number of those obviously very sick, very intensive care type patients, and that has driven length of stay up. Our emergency room has been, I'll say, at about 80% of its pre-COVID volumes, and that's an area that does not seem to have changed dramatically over the period. As we've seen surgeries come back online, I mean, clearly we've seen surgery come back and it kind of ebbs and flows. It feels like at times it seems like we're having, a number of very good weeks and then it'll soften a little bit and we get very concerned that it's softening and then it picks back up. The other thing has been in our average daily census and kind of these COVID surges, we've seen them differently at different hospitals across our system. Northwest Hospital, which is, one of our community-based hospitals, really in the spring saw proportionately our highest volume of COVID surge activity. It saw a tremendous increase. And here at Carroll did not experience that as much in the spring, but then in November and December and early January experienced it proportionately more than our other hospitals. So it's been unusual in that regard that we've seen it differently at different hospitals that, in my opinion, aren't tremendously far afoot from each other geographically. But I would say at this point in time, have not seen our EDs come back. That's the one thing that seems to have really not gotten back close to what the pre-COVID levels were. And then surgeries, hit or miss, and census has been pretty strong.
I would just add to Mike that we probably mirror that. I think it's going to be a challenging budget and planning year, trying to figure out what's going to bounce back and what's not. Advisory board has said that they feel that COVID took out the unnecessary care in the emergency room. And so they think that will not bounce back. And we also know that there was a lot of pivoting to urgent care centers during that time. So that path is probably, I think, going to be a permanent change. We haven't seen surgery return, and that's concerning. We actually are full in our ICU right now. We actually sent a patient out to Anne Arundel for just a normal surgery, believe it or not, last night. So that's a long ways to go to having capacity. Our nurses are, Sino was just saying that what we have in the ICU right now is sicker patients, not necessarily COVID, but sicker again. And I know there's always that jump to make a conclusion that it's because this or that, but there is that thought that there's a lot of postponed normal kind of screening and just going and seeing your doctor for prevention that is starting to possibly show up in our intensive care units now.
So I just want to make a comment about the emergency room reduction. It's been permanent here. We're down probably 30%. And so then we have the challenge that our emergency room physicians are not employed by us. So then now they're saying we may need a subsidy. So it's bringing up, I think, I actually think this emergency room reduction is probably going to be permanent. But then we have those of us who don't employ our physicians having to make them whole. Whole nother discussion, but that's just another challenge.
Have you seen any effect on your fundraising during the pandemic?
Okay, so we're jumping to fundraising. And so, Chip, no. As a matter of fact, our fundraising this year was almost as high as it's ever been. which has been remarkable. And one of the things that we've done, and I like to ask my colleagues, sending up a workers fund. So the community has, donated about $700,000. And we have been using that money for hardships. So for employees, maybe spouse gets sick, they lose their job, can we help them? Mediation, we have a mediation bus that's available for employees who may feel like they need help. So I would say from GBMC's perspective, fundraising has actually improved during this whole pandemic, not to mention all the meals and other things that came into the organization during that time. So I'd like to hear my other colleagues speak to that.
Yeah, no, I was going to say, Laurie, it's actually been very moving, frankly, that the communities have supported our organizations during this time in the manners that they have, and not only through contributions, but through doing things, whether it's gift cards, whether it's through meals. It really has shown the level of engagement our communities have with our hospitals. We also had to early on cancel a very major fundraising event for Lifebridge, and the vendors, the participants really didn't pull back from it. It was tremendous, the support that we've continued to receive throughout the process. So very gratifying, very rewarding.
And I think it's also caused us to rethink our fundraising efforts. So I think, most of us have some sort of either an annual golf outing, a gala, some of those larger events as our major fundraising. Going to virtual events, it's causing our philanthropy to shift for sure.
Yeah,
that's a good.
Go ahead, Mike.
I've been amazed at how effectively our development departments have been able to do virtual events, to do what they call, in a box virtual type events, and still have them be really, really nice activities and events.
I was just going to add that the development department was amazing. If there was anything that someone at the hospital needed, because of their connections to the community,
Yes.
they could pick up the phone and get this and get that. And so don't underestimate the power of your development team. And additionally, our volunteers, I don't know, they probably made 2,000 masks. They came together, sewed up at the beginning masks. And then if you look at fundraising in terms of pizzas, man, we were in the thick of it, because we got a lot of pizzas delivered from people that were just generous sorts.
Yeah.
Great. Yeah, my wife was one of those that made masks. She's pretty good at sewing, and she made well over 100 masks for one of the local hospitals.
Oh,
All right, let's jump to Laurie's favorite subject.
Oh my gosh.
According to Modern Healthcare, 2020 saw about 240 breaches involving network servers through November, 95% increase over 2019. Laurie, I know you can't describe this in absolute detail for legal reasons, but why don't you tell us what you can about the ransomware attack?
I can. So just, I'm going to give you a couple gory details. So you wake up on a Sunday in December and you get a message that you're being attacked, and printers all over the organization are, sending these messages. So just a couple of things. I can't really disclose conclusion because we're still trying to figure it out, but we have been working over the years on, the phishing attacks with the employees and all these levels of security. But once we identified it, if I am just telling everyone, you need cyber insurance and you need a cyber attorney who can support you. So the day that it happened, on the phone with them, and then they identified forensic IT folks who were looking to see how it happened, as well as we had a negotiator, if we identified who it was, to give us the keys to the car to open everything up. It turns out we didn't figure that out, okay? So once we did that, we built the infrastructure back. We had people around the clock building the infrastructure so that we could get back. And I'm happy to report that we got our physician practices back in 17 days and the hospital back in 28 days. Lessons learned. Do not skimp on infrastructure, legacy systems. So those of us who have Epic, which we have, Cadillac, EMR, all these different systems that attach onto Epic had not been upgraded. And those are the systems that got attacked. So what we've learned is we have got to get all those systems up to 2021 standards. Okay. And that includes pharmacy. I mean, we have all these pharmacy systems that Epic doesn't have. That was probably the biggest issue. And then when we went to Epic in 2016, we had Meditech, ECW, and Cerner that needed to be supported. They were attacked. So just make sure that your IT folks are focusing on infrastructure as well. The other thing we learned is we had IT people in all these different areas. And so when we got attacked, our system IT is supposed to support those areas, but the IT resources in those areas didn't have the skill sets. So now we're in the process of centralizing IT. And then finally, make sure you have downtime procedures, because we built them on the fly as far as forms, as far as workflow and all that. So I think I could go out on the consulting circuit after going through this, but really the idea is just need to make sure that us as CFOs make sure that our IT systems are up to the 2021 standards. That's the takeaway.
Yeah,
Anyone-
Laurie, I can't imagine what it was like to live through that. We try to do some tabletop exercises and that sort. So, it was always a scare to me to not have proper backup for any disaster in terms of just having, old-fashioned hard copy. But
Yep.
just to, I don't think Frederick is any different than any of you, but some of the things that we are doing, and I'll just run through them, obviously starting with the cyber security type assessment so that you get your consultants in there and they work through that. We are now having, we put the spam filters in. So my God, it's wonderful. There goes half of your junk mail, like maybe more like 90% of your junk mail. And maybe
Yes.
1% of good things get caught, but that's worth it. So those spam filters are up. I would say it may be 2, 3, 4 times a week that we're getting updates that we have to reboot, our machines now, because they're trying to respond to everything that the FBI comes out with about, there are a lot of bad guys out there, and our wonderful web has, as we know, in so many ways, has just turned into being, that risk. Now, one of the other things we do is phishing exercises. And I don't know how many of you are doing this, but we are kind of putting some teeth into it. So, we'll send out the funny little email and see who clicks on it. And then, at the point in time, we were saying, okay, we need to educate more. So we educated. We make a CBL a requirement, just like we do our mandatories every year. We now have a CBL for cybersecurity that is education. And then they're getting, the little exercises. We looked at who has access to the internet that has no reason to have access because of their job.
Yep.
We cut that off.
Yep.
And then in this phishing exercises, we are contemplating a 3 strikes and you're out. In other words, within a period of time, and I think it's like 6 months. If you click on a phishing email by mistake 3 times, it's reason for termination.
Okay.
And I know that seems really dramatic, and I'm kind of like scared myself to think that, if you're going to say that, it could affect everybody. It could be a vice president, it could be anybody. And are you going to stick with that? And so our boss came up with the great idea about, well, maybe you could earn them off. Let's say you've got 2 strikes. Well, maybe if you're clean and not clicking for 6 months or 3 months, you could get a strike back and then, you're back in. But, if you think about it, it's one time.
Yeah.
It's just one time and you could be in real trouble. So to continue to work on that, I just think is absolutely critical. And then I would agree with everything that Laurie said. And it is my understanding that when you have an incident that your liability insurance will come in and kind of take over and will also provide legal guidance. And you're more an expert because you've lived it now, Laurie, than I am.
Yes. To make sure that you have we have Beasley, and they were very savvy in helping us navigate through this, but I cannot emphasize what Michelle just said. We had phishing exercises every quarter. We since I've been at GBMC, we've been doing all of this. And I cannot emphasize making sure your clinical folks know how to work offline, do downtime procedures during the day so that our nurses and doctors know how to work without Epic. And there was a lot of pushback before this, but now they get it. So, and what I'm told, it's not if, it's when. Okay, so yeah.
All right, we're almost out of time. Let's kind of try to get into one last area, and that's physician relations. Certainly unregulated revenue was probably one of the hardest hit areas during the pandemic for our Maryland hospitals. How's your relationship with your physicians changed during the pandemic? And have you had to lay off any physicians or change their compensation models? Anyone want to tackle that?
Okay.
I can.
Go ahead.
Sorry about this. I'm really happy for Mike or Caroline. I really don't want to be. I'll try to be brief to make time for everybody else then. The answer is no. The physicians have been paid, we've kind of kept them whole. And, what we found, and I've talked to other systems, there were so many doctors trying to get out of New York that there was obviously just a really easy market to hire physicians in places that were further away from New York. So, some of the issues that people were having were actually improved because of COVID, and doctors became more available. So I would say when you asked about how their morale is, they basically moved quickly to, as we talked about, the telehealth. So I don't believe that there's anything particular. There's not nervous. They've gotten their dollars, so I'm not seeing anything. And I'll stop at that point. And Carolyn, maybe you would like to take it from there.
Sure. Our employed medical group is on a productivity model. So we definitely had to go back and modify those to keep them whole, to your point, so that they weren't negatively impacted. I would say that we've had a few in our practice that I believe moved up retirement, thinking about, do they want to do this again? Technology and telemedicine was a bit challenging. We didn't have a plan to deploy telemedicine. So, we threw it together quickly, and it worked out well, but I believe that some of our providers, still struggled with that. So from that perspective, yes, we did change their compensation, but it was really to keep them whole. But to Laurie's earlier point, we also are hearing some of our contracted providers, coming for more money because volume isn't where it used to be, that they're coming up short in various areas. So it is a mixed bag, but overall, just part of the job, just those negotiations and trying to determine how long we will be in these decreased volume situations.
One final question for me. Price transparency rules nationally went into effect January 1. What have you all done differently?
All right, I'll jump in and then I want to hear what my other three colleagues are doing. We have our hospital like sort of top 30 procedures pricing out there. Where we've struggled is being able to disclose rates on the professional side from all of our payers. And our guidance from our general counsel is we have to do that. But we are in discussions with, our Care First, our Aetna, Cigna, and we haven't pulled the trigger on it yet because we feel like even though we need to comply with CMS, we have contracts with our local players and partners. So we have not disclosed the Part B side yet. So I'm curious as to what my colleagues are doing.
Mike, maybe that's one for you.
Yeah, Mike, we talked about that last week.
Yeah, it's, we've had some consistent experience. Obviously, we've put out the shoppable services, as required by January 1st, but have similarly struggled more in kind of the professional and what to do there and being able to link it and so forth. So we're still working through that similarly. Yeah,
Okay.
very consistent.
Hey, Michelle, Carolyn, what are you all doing?
Well, yes, we're in agreement that, we have been posting charges out long before this, but now with the shoppable list modifying for that. But physician services are really the struggle. Really,
Yes. Yep.
we haven't deployed any new software. We haven't contracted with anyone to help facilitate that for us, but know that it might be something we have to look at going forward.
And my piece would be that about 3 years ago, we brought Experian in and put a price estimation software in place. So we can provide not just the website, but also out of pockets for people and for better or for worse, I'll call it a broad estimate of what their costs will be.
So
Cheryl, I'm
Michelle,
going to turn it over to you.
actually, I want to ask Michelle, is that out on your website? So a patient can click onto
I
that?
don't think it is, Laurie. I
Okay.
think you have to call
Okay.
for it.
Hi, everyone. I just want to take this opportunity to thank the panelists and thank Chip for moderating. And I'd like to thank Kalita Burton, who you often don't see in the background on these calls, who is our Zoom engineer. Also want to thank our sponsors, and Kalita will share that slide in just a moment. This has been great information, and we appreciate listen all day to these folks with so much experience as CFOs in Maryland and elsewhere. Just a reminder that you'll get an email from HFMA with an evaluation. The way that we continue to provide programming that you want and like is from your feedback. So please fill out the evaluations. I do want to put in a quick plug for our HSCRC workshop part 2, which is next Friday, February 26th. Registration is open. And also our Women in Leadership event is March 5th. It's a Friday and it's sponsored by Berkeley Research Group, and there'll be a trivia networking event immediately following. And then also I just want to remind you that we are offering a CPE for today, and those forms will go out also when the email goes out for the evaluation. So I think that concludes our session for today. And again, thank you to our panelists. Excellent discussion. Thank you, Chip. Have a great day.
Thank you all. Bye-bye.
Thank you.
Have a good day.
Bye-bye.
Thanks.